Yes, sir.
We can start now. Mhm.
Okay. Um, will you give us introductory slides? Good evening, everyone, and it is a pleasure today to have all of you join in for once again the Wednesday IDEC Cafe. With me is Dr. Sanjay Agarwal, sir. We have a team from IDEC, and we bring you very interesting topics and good speakers from across the globe. And we have our audience from all the continents in the world joining us on the last Wednesday of every month for the Wednesday Cafe. Today, we have a very esteemed panel, Dr. Ganesh Jewalikar and Dr. Arundhati Dasgupta. First, it's a pleasure to introduce and welcome Dr. Ganesh Jewalikar. He is a pediatric endocrinologist. He's the past secretary of ISPE. He has 22 index publications and several book chapters. He's a co-author of the ISPAD guidelines on hypoglycemia in type 1 diabetes and on the editorial team on ISPE congenital hypothyroidism. He is very well studied, very passionate about his topic, and it's a pleasure to have him with us today. Welcome, Dr. Ganesh Jewalikar. He is going to take us through the topic of classification and diagnosis of diabetes in young. Today, we are going to talk about diabetes in young, whether it is adolescents or young adults. Initially this, and later on specific about type 2 in young people. With this short words of welcome, I hand over to Dr. Ganesh Jewalikar to present his talk.
Good evening, everyone, and thank you, Archana ma'am, for that kind introduction. Good evening, Agarwal sir.
Good evening.
I am a pediatrician by background, and my clinical experience pertains largely to pediatric and adolescent age group. Although some of the principles that we learn are applicable to young adults too. This is a very important topic. I'm just sharing my slides. So I hope that they're visible. In the first part of the session, we are going to discuss about diagnosis and classification of young onset diabetes. Now, this is not a book entity. Young diabetes there's no academic or book definition for what is exactly young onset diabetes. I mean, maybe 20 years back, if somebody got diabetes at 35 years of age, people would say that it is young onset diabetes. But the scenario has changed with respect to diabetes and decline in the age of onset. We see increasingly younger people getting diabetes. And often we are faced with dilemma about what exactly is the type of this diabetes. We will start with a case scenario because before even we go to classification, with respect to pediatric population, at least we face challenges with respect to even diagnosis of diabetes. So let's start with this scenario, which I had seen a couple of years ago. So this was a 6-year-old female child who was noted to have excessive thirst over past 2 weeks. And the mother did promptly take her to a doctor who said that it's fine, it's winter season, children drink water. I mean, it is absolutely fine for the child to be like this. There's nothing wrong with the child. Uh, then, so the mother went back because she was reassured by the pediatrician. And then in the second visit, basically after a few days, she said that no, something doesn't seem right. The child is becoming weak. So at this point, she was prescribed some vitamins and some glucose solutions or oral some drinks to for the child to have. And then a day after that, the mother telephoned that the girl is having some abdominal pain and vomiting. And symptomatic treatment was given MSET or ranitidine or things like that. And as expected, the child ended up in emergency, admitted in ICU with altered sensorium and respiratory distress with a very high blood sugar levels. Now, this is not an uncommon scenario. I have witnessed this scenario in the national capital. So I'm sure that in the peripheral institutes, these kind of scenarios must be very, very common. And it is not uncommon for the diagnosis of diabetes, although it looks very simple when we read it in books, but delays in diagnosis of diabetes are very, very common. This is true not only for India, but also across the world. We see that whenever there is a background incidence of diabetes, or particularly childhood diabetes is low, delay in incidence, a delay in diagnosis of diabetes is common. This delay is not benign. This delay is associated with higher glucose levels, higher HbA1c at presentation, and higher incidence of decay. So if we see delayed diagnosis, nearly half of these children, or about 60-70% of these children, could directly present in diabetic ketoacidosis. Not only does this raise the risk of hospital admissions, possible morbidity and mortality, but also it is now known that those who present with decay have long-term impact on their brain with respect to brain structure as well as function. And if children present with very high sugars and poor glycemia at the beginning, they continue to have that kind of a glycemic profile for a longer period of time. So this is particularly important because that raises a question that we have to make all possible efforts to pick these children up in time so that we prevent this, and not only prevent the acute morbidity and mortality of decay, but also make an impact on the long-term management of this diabetes. There are several common reasons for delay. The most important thing is not to think about diabetes as a differential diagnosis. So, I mean, for an endocrinologist, it is very easy to, diabetes would come as a first diagnosis for an endocrinologist. But for a pediatrician or for a general physician who is seeing a lot of other conditions, they may think of things like sometimes the symptoms are blamed on to winter season or so-called healthy habit of drinking drinking water being like a little healthy thing. And sometimes it is wrong diagnosis that the diabetes is being confused with either some abdominal infection or surgical abdomen or pneumonia, asthma, etc. Even there have been cases where the child has been suspected to have meningitis and they do CSF examination, and in the CSF they found the blood sugars to be very high. There have been cases where patients have been opened up surgically thinking of it as a surgical abdomen, but actually it turns out to be metabolic acidosis of diabetic ketoacidosis causing abdominal pain. So these are some of the reasons for delayed diagnosis of diabetes. So, I mean, the most important takeaway point from here, and this message has to kind of be spread across the community, across the general community, that whenever there is a child who is passing excessive urination and drinking too much of water, this is not frequent urination. Remember that there could be a frequent urination in a UTI, but that is urgency and frequency. The volume is not increased there. So when we say polyuria and polydipsia, the child is passing frequent urine in large quantity. So the volume is also more. And excess hunger, despite of excess hunger, the child is not gaining weight or child is actually losing weight, is feeling tired and feeling weak, having headaches or dizziness, etc. So polyuria, polydipsia, weight loss. The first and immediate instant reaction should be to check a capillary glucose at least immediately. And one should not waste time doing glucose tolerance test or fasting PP test in such cases. Here, the urgency of treatment is what is more important. So just a random glucose or a capillary glucose or a urine examination, these investigations are enough for you to start the treatment. You don't need to waste your time. Often we get referrals late in the night because they say that the doctor had advised the blood sugars to be checked fasting and PP or glucose tolerance tests, etc. That's not required for most cases of type 1 diabetes. Some other presentations include secondary nocturnal enuresis, which means that the child had stopped, had achieved bladder control, but has started bedwetting again. Recurrent sty or skin infections, vaginal or oral candidiasis, or even with respect to, I mean, we have a very small percentage of cases of type 1 diabetes, actually. We've been picked up for some non-specific reasons or I mean, probably less than 1% cases, but some of them were asymptomatic too. In emergency, in cases of respiratory distress or altered sensorium or abdominal pain, in surgical abdomen kind of a situation, one of the differential should be diabetic ketoacidosis. In a child who is apparently, in a dehydrated child who is passing normal or excessive urine, despite of being dehydrated, one should think of diabetes mellitus. The criteria for diagnosis of diabetes in children or young adults are not different from older adults. So the only important points to remember here are that if the child has classic symptoms of polyuria and polydipsia, just a random blood sugar of more than 200 milligram per deciliter is enough to make a diagnosis. There is no need to document fasting PP or HbA1c or anything like that at that point in time. The other criteria are important with respect to other types of diabetes or type 2 diabetes, etc., which includes fasting glucose of more than or equal to 126 and 2-hour post-glucose load. Here, the thing to remember is that in pediatric, particularly in younger children, the glucose tolerance test has to be done using 1.75 gram per kg. Not everybody receives 75 gram. Obviously, the maximum amount that we give is 75 gram of anhydrous glucose. And HbA1c more than or equal to 6.5, although we must remember that largely this number has been derived from adult studies, and using HbA1c alone as a criteria, particularly if the value is just borderline abnormal, may sometimes be fallacious. Or on other side, if HbA1c is relatively normal, but the blood sugars are clearly indicative of diabetes, then it could be a recent onset of diabetes, and we should give importance to the blood sugar readings there. So what are the types of diabetes? Moving on to classification, what are the different types? I mean, the ADA classifies them as type 1, type 2, other specific types, and gestational diabetes. In type 1 is further divided into where there is evidence of autoimmunity, type 1A, and the absence of autoimmunity is called as idiopathic type 1 diabetes, that is type 1B diabetes. The other specific types is an umbrella term, which basically includes a lot of conditions which are genetic or acquired, syndromic, and some endocrine conditions like Cushing syndrome, which are associated with diabetes. Why should we bother to classify the type of diabetes? Why can't we just start the treatment based on the initial presentation? It is extremely important because there are implications of making a specific diagnosis. For example, if you're making a diagnosis of type 1 diabetes, as of now, the type 1 diabetes has to be lifelong commitment to insulin. But at the same time, you'll think of other autoimmune conditions like hypothyroidism or celiac disease. If it is type 2 diabetes, there is a plethora of options of treatment available, although that is a little bit limited in pediatric age group. But mainly with respect to type 2 diabetes, we know that young type 2 diabetes has other metabolic comorbidities like hypertension, dyslipidemia, fatty liver, etc., and higher risk of complications at the onset and generally poor adherence to treatment, at least in my experience. If we make a diagnosis of MODY, we have variety of treatment options depending on what particular gene is affected. Some of them may not require any specific treatment. Others may require sulfonylurea, and some of them may require insulin treatment. So MODY is quite variable. If we make a diagnosis of neonatal diabetes, this is a specific type of diabetes which is seen in the first 6 months of life. Here, proving a K-ATP channel mutation, we may be able to try sulfonylurea as a treatment for these young infants. So moving on to a few cases to just discuss this matter further, this is an 11-year-old girl who presents with polyuria polydipsia of 1 month. She has lost some weight and she is admitted in an emergency department with respiratory distress and vomiting of 2 days duration. Her blood glucose is more than 600. Her ketones are 3 plus. There is no history of diabetes in parents. She weighs 30 kg and her height is 142. She is not overweight or obese. She does not have any signs of insulin resistance. What do you think is the type of diabetes in this particular case? I mean, if you are able to put it in chat box, maybe you can just say 1, 2, or for other types you can say 3. What do you think? It is 1, 2, 3. What type of diabetes it is? So I'm not sure if the chat is working or not, but this is clearly, there's no confusion in this case. This is clearly type 1 diabetes. So most cases of type 1 diabetes do fall in this category. We don't really have to do a lot of investigations or spend a lot of money doing all sorts of tests. It's quite clear, a lean child presenting with very high sugars or ketoacidosis or ketosis without a family history of diabetes and no signs of insulin resistance, the diagnosis is type 1 diabetes. I mean, this is true for most cases of type 1 diabetes. Let's talk about another case, which is slightly different. Now, this is a 7-year-old boy. He was taken to a doctor because he was not gaining weight. And as a part of the test showed fasting glucose of 128 and HbA1c was 8.1. Now, this child was treated elsewhere. But when I asked him, in the last week they saw me, when I asked him, was there any other symptom? So they did say that the child had started wetting the bed again. The child had basically secondary nocturnal enuresis. This child is 20 kg. He is not obese. He does not have signs of insulin resistance. He does not have family history of diabetes. So what type of diabetes is this? Do you get any doubts or any dilemma? This child does not have ketoacidosis. This child does not have very high sugars. The HbA1c is also slightly high. So the doctor rightly performed some tests and they did anti-GAD antibody and they did C-peptide. So because the GAD antibody was negative and the C-peptide was reported to be in the normal range. What do you think? Now, what do you think is the type of diabetes? Some of you may think that this is type 2 diabetes, or this is probably some other type of diabetes. So this child was started on treatment with sulfonylurea. And this is a real scenario. This is unfortunate but real scenario. And the HbA1c was 7.1 in May 2023. This happened, the story started December 22, and the HbA1c was 7.1 in May 2023. Doctor is happy, patient is happy, blood sugars are well controlled. But what is wrong? Past few months, and the child has high sugars, HbA1c of 8.5, and now 8.8, sorry, and now requiring insulin. So what went wrong? Some bookish knowledge that antibody negative means not type 1 diabetes. Some not clarity about how to interpret C-peptide, and lacking a common sense that at 7 years with this kind of sugars, without a family history, without any signs of insulin resistance, it can't be type 2 diabetes. It simply cannot be type 2 diabetes. Remember that type 1 diabetes is the most common type of diabetes in children. And therefore, if you are making a diagnosis of type 1 diabetes, you are statistically more likely to be correct. There are antibodies which are used, but if you are only using GAD antibody, about 30 to 40% of cases of type 1 diabetes in India can be GAD antibody negative, particularly children. GAD antibody is slightly more positive in adults with type 1 diabetes, but in children, about 30 to 40% cases can be GAD negative. So if you have option and if your cost permits, please do the entire panel of antibodies, not only GAD antibody. So any of the antibody is positive confirms type 1 diabetes. But if you have negative antibodies in about 10 to 20% of cases, you can still have the type 1B or type 1 diabetes. So antibodies can be negative in, despite of testing all the antibodies also, antibodies can be negative in a small percentage of cases. The titer can change over a period of time. At diagnosis, some of the antibodies are positive, but over a period of time, their titer may wane. Then something like insulin antibody is useful only before you start the treatment with insulin. Once you have started the treatment with insulin, the insulin antibody may just indicate a response to the exogenous insulin. So this is what we must remember, that antibody positive, yes, it helps for type 1 diabetes diagnosis. Negative, especially if the clinical picture is suggestive, negative antibody per se does not rule out type 1 diabetes. So, and as I was saying, that it's been shown in some of the Indian studies that there is a high prevalence of antibody negative diabetes. But if you test 4 antibodies, probably 70-80% might be positive. Then the next, so what has changed is basically we have now understood that type 1 diabetes is not always the classic, acute, subacute, or stormy kind of diabetes that it is always described to be. It can be very variable. It can have a variable rate of progression. And therefore, even the C-peptide, which is used as a kind of surrogate marker for insulin secretion, can be variable in the first 2 or 3 years of diabetes onset. So this particular study shows that residual insulin secretion may be present in about 30% individuals with type 1 diabetes for up to 2 or 3 years after diagnosis. So only if you have a low C-peptide after 2 or 3 years, that is kind of suggestive of type 1 diabetes. In the first 2 or 3 years, you could have overlap in type 1 and type 2 diabetes. Coming to next case, this is a 16-year-old boy who presents with weight loss. There is a history of type 1 diabetes in the system. But this boy is significantly obese. He has signs of insulin resistance. His HbA1c is 12.8%. His random blood sugar is 222. His SGPT is elevated and he has evidence of fatty liver. And his urine ketones are negative. He is clinically otherwise stable, not decompensated. And this is his neck. So you can see clear acanthosis. Sometimes we have to see axilla or other skin folds also to demonstrate or to rule out acanthosis. So what is the likely diagnosis in this case? Now, this child is likely to have type 2 diabetes. Although there is a history of type 1, family history of type 1 diabetes, that does not prevent him from getting type 2 diabetes. So how common is type 2 diabetes in children and young adults? This was our data of about 700 patients in the place where I used to work. So in under 18 onset, about 7 to 8% cases were of type 2 diabetes. But when we go to 19 to 25, if we shift slightly into older or young adult age group, about 30% of them could be type 2 diabetes. Still, even in this age group, type 1 diabetes is more common than type 2 diabetes, but type 2 diabetes is slowly increasing, particularly in this age group and also in some of the teenagers. This is the table showing comparison of type 1 versus type 2 diabetes, the parameters at the onset. You can see that parameters such as older age, family history of type 2 diabetes, a stronger family history of type 2 diabetes, less prevalence of symptoms. So more of incidental, more statistically significantly more common incidental or other presentations like candidiasis, etc., are more common with type 2 diabetes. But remember that about 40% of them could have symptoms. And family history of type 2 diabetes is not only unique to type 2, it could be present in type 1 diabetes also. Similarly, a small percentage of type 2 diabetes could have GAD positivity, particularly slightly positive titers, not a very strongly positive titer. Then in terms of overweight or obesity, obviously type 2 in young age group often exclusively happens in the background of overweight and obesity and family history. Without that, suspecting type 2 in a child is a little, unusual even now. But the type 1 diabetes people can also have obesity rates which are prevalent in the general population. So about quarter of our type 1 diabetes were falling into overweight or obesity by BMI criteria. So the table was meant to show you that the clinical parameters are helpful, but they are not exclusively, able to for us to discriminate between type 1 or type 2 diabetes. Rather, actually, I would say that there's not a single parameter which is 100% sensitive and specific to tell us that the child has type 1 or type 2 diabetes, other than positive antibodies. So coming on to the next interesting case, this is a 16-year-old boy who presented with DKA after heavy physical exertion. He was obese. He had high blood sugars, but his amylase and lipase were significantly elevated. There was history of diabetes in mother, and his father also had diabetes, and he had premature CAD, and he passed away of CAD. Now, what is this? This is a young boy presenting with ketoacidosis. He is obese, he has signs of insulin resistance, and his pancreatic markers are also elevated. So what type of diabetes is this? Type 1, type 2, pancreatic diabetes? What is it exactly? Now, first and key message here is that at this point, probably it is not relevant what type of diabetes he has. It is important that he has ketoacidosis and he's decompensated and he needs fluids. So ketoacidosis has to be managed similarly, irrespective of whether it is type 1 or type 2 diabetes. That child would need fluid, that child would need insulin infusion, need electrolyte correction, etc. After that also, this child should be started like type 1 diabetes treatment. This is a decompensated case with very high sugars, and it should be started like type 1 diabetes. And after that, you can take your time to evaluate the child and tell whether what type of diabetes this child has. So learning, irrespective of initial diagnosis, patient with severe hyperglycemia or DK need to be managed with insulin. If you think that there is a possibility of type 2 diabetes, you can add metformin later on once the child is stable and increase metformin and try tapering insulin. Remember that in type 1 diabetes also there's something called as honeymoon phase where you are able to taper insulin in some cases. That fact has to be there in the background. There is a role for documenting antibodies, C-peptide, etc. But C-peptide in the initial phase in decompensated type 2 diabetes can be low. After a few months, a few years, it is more useful parameter. So ultimately, the gold standard is long-term insulin requirement. People with type 1 diabetes cannot be managed with anything other than insulin. So this case, subsequently, pancreatic imaging was normal. The lipase and amylase did settle after the DKA treatment. Antibodies were negative. He was also tested for MODY, and that was negative. And he demonstrated further weight gain, acanthosis, sleep apnea, and hypertriglyceridemia and hypertension. So that made us confirm a diagnosis of type 2 diabetes in this case. So to summarize type 1 versus type 2 diabetes, if you have a lean child with high sugars, acute, subacute kind of presentation, no signs of insulin resistance, no family history, particularly with ketosis or ketoacidosis, that child is likely to be type 1 diabetes. Whereas an obese child detected around the time of puberty or after puberty, incidental diagnosis or mild symptoms, signs of insulin resistance, family history of type 2 diabetes, that child is likely to be type 2 diabetes. If you have overlapping clinical features, you need help of tests. And often the tests are helpful in some cases, but they may not be exclusively, 100% telling us. And therefore, sometimes we may have to rely on the clinical course of the child. If you're confused, you will never go wrong if you give insulin, irrespective of what the type of diabetes is. If you're confused, treat with insulin. Coming to next case, this is 11-year-old boy with incidentally detected high sugars. He was just checking his sugars alongside his father, and his blood sugars were in this range. Antibody panel, entire panel was negative, and C-peptide was detectable. If we see the family history, his father was also lean and got diabetes at very young age. His sister and sister's daughter also had young onset diabetes, and grandfather also had young onset diabetes. So this made us send genetic testing for this child. And the genetic testing showed presence of HNF4A, that is MODY3. Now, this was helpful because establishing diagnosis of this child helped in diagnosis of other individuals with diabetes. And also his brother developed high blood sugars exactly at the similar age. And we were able to tell that this is MODY and not type 1 or type 2 diabetes. So we could manage him a little more proactively. So making a genetic diagnosis is important in suspected monogenic diabetes. Subsequently, this child responded to sulfonylurea because it is a transcription factor MODY. These children have, over a period of time, they have insulin secretory failure also, and they require insulin treatment. So now he's on basal bolus treatment. Actually, as of 2022, he's on basal bolus treatment. So, so genetic testing should be used in cases where we are suspecting a genetic type of diabetes. I have a list of, I have a slide in the subsequent presentation where when to do genetic testing. But some other case examples, this is a girl with non-autoimmune insulin-dependent diabetes. And then she subsequently presented with hypocalcemic tetany. And when she walked into OPD, she had this ptosis, bilateral ptosis. So this is a multisystemic kind of involvement. Multisystemic involvement favors mitochondrial disease. So she had mitochondrial diabetes. This boy was being treated as type 2, young 25-year-old, but you could see that he's very muscular looking, so-called muscular looking, and his body composition showed that he hardly had any fat. So he had generalized lipodystrophy. This is a classic X-ray showing calcifications in the pancreas, fibrocalcific type of diabetes. So, I mean, there are other types of diabetes which contribute to about 3, sometimes if you consider pancreatic diabetes, even up to 10% cases of diabetes amongst youth. So we should kind of keep our eyes and ears open for these types of diabetes. So when do we suspect other types of diabetes? In terms of monogenic, first 6 months of life is neonatal diabetes. Type 1 diabetes does not happen in first 6 months of life. In 6 to 12 months with negative autoantibodies. In other older individuals, if you have a family history suggestive of autosomal dominant inheritance, it is not necessary always that you have a 3-generation family history. You could have indicative family history. And if you have apparent type 1 diabetes with atypical features, negative antibodies, or preserved C-peptide even after 2 years of diabetes onset, and apparent type 2 diabetes without significant obesity or insulin resistance and unusual fat distribution. These are the indications of genetic testing. We should use genetic testing more proactively now that it is available. In other cases, if you have history of recurrent abdominal pain, steatorrhea, exposure to steroids or some anti-cancer chemotherapy drugs, some anti-transplant drugs also. Then systemic disorders such as thalassemia major, where we know that diabetes can be a complication of iron overload. Syndromes such as Prader-Willi syndrome, Klinefelter, Turner syndrome, and features of severe insulin resistance. Features like deafness or optic atrophy, which could indicate Wolfram or mitochondrial kind of diabetes. So these are the situations where you would consider other types of diabetes. They are not rare. We should kind of keep our eyes open for these diagnoses. Almost to summarize, I would say that if you have diabetes onset after 30 years, but beyond first 6 months or beyond infancy, you see whether how is the onset, how is the severity of symptoms, ketoacidosis, etc. If you have these and if you have positive antibodies, that confirms type 1. If you have these despite of negative antibodies, you would probably still manage like type 1 diabetes. If you have obesity or insulin resistance features and family history of type 2 diabetes, that person is likely to have type 2 diabetes. But in the absence of obesity or insulin resistance features, one should consider using genetic testing to rule out monogenic type of diabetes. So to conclude, I mean, the most important message is that we should not miss diagnosis of diabetes. So if you have classical symptoms, if anybody calls you saying that these are the symptoms the child is having, please check the blood sugars. Early diagnosis is important to have better long-term outcomes. Remember that most common type of diabetes even now is type 1 diabetes. Type 2 diabetes is increasing, but at least if you're dealing with people under 18 years of age, remember that type 1 is the most common type of diabetes. And we should definitely use genetic testing on a slightly more wider basis than we were doing so previously. and we will pick up diagnosis of monogenic diabetes. I'm sure that many of them are being managed as type 1 or type 2, but they're being missed because of lack of genetic testing. Thank you so much for this opportunity. Sorry.
Thank you, Dr. Ganesh. That was a wonderful and a very comprehensive talk. We have more than 900 people logged in right now, and a lot of questions are pouring in. I would ask all our viewers to do write their questions into the chat box. We are receiving them, and after we hear our next speaker, we would be having a panel discussion, and our specialists, our speakers will be happy to answer all the questions. Thank you, Dr. Ganesh. And now it gives me great pleasure to invite our next speaker and to welcome her, Dr. Arundhati Dasgupta. Welcome. Welcome to IDEC Cafe. It's a pleasure to have you. You'll have to unmute yourself. Yes. So she's the Director and Consultant Endocrinologist at Rudraksh Super Specialty Care in Siliguri. She is a winner of many awards, such as the A.V. Gandhi Award for Best Thesis, the Diabetes Awareness Initiative, the Young Achiever, the ESI President's Appreciation Award, the RSSTI Innovation Award, and the Icon of Endocrinology Award for this year, 2024. She's a course coordinator for PHFI and several other national training programs. She presents beautifully, and I've heard her very often at various national and international platforms, and an author to many publications. It's a pleasure to have you here, and she will be taking us through type 2 diabetes in the AYA population, that is adolescent and young adults. So as we heard Dr. Ganesh talk to us in the younger population, and especially other than type 2, deliberately, we left type 2 to be specially focused on by Dr. Arundhati. Over to you, ma'am.
Thank you so much, Dr. Archana, and thank you for that kind introduction. Please allow me to share my slide.
Again, viewers, please do keep writing in your questions in the chat box. We will be taking them at the end of this talk. Thank you.
So good evening, everybody. It's a great pleasure to be here as a part of this very interesting program. And I've been a part of the audience a number of times, and it is indeed a great privilege to be as part of the panel here. And the topic that has been assigned to me is a very interesting topic. We'll basically be discussing about type 2 diabetes in adolescents and young adults, as has been said by Dr. Archana. Now, when we talk about type 2 diabetes, remember just till around 4 decades ago, when we, another name for type 1 diabetes was juvenile diabetes, and type 2 diabetes was called adult onset diabetes, right? A little later, maybe around 3 decades ago or so, there were case reports that were coming in from clinic-based investigations that, type 2 diabetes cases are also, being seen, and there are studies which were monitoring youth onset type 2 diabetes trends. Bring it to today, where in some countries, in some non-racial and ethnic groups, the incidence of type 2 diabetes in adolescents is twice that of type 1 diabetes. Admittedly, I mean, across the world, still type 1 diabetes numbers are higher when you're talking about this age group, the adolescents and the young adults. But the rates at which the numbers are rising, in each country, we'll just take a look at what is happening in terms of the epidemiology. And this is the global incidence of type 2 diabetes in children less than 20 years of age, and this is per 1 lakh. And you can see the numbers. India stands at the second highest after China. And you can see that, across the countries, as you're looking at the numbers, I mean, it's just there at, where at the top, where you're talking about New Zealand or the UK or Finland, where the numbers look, less than 1. But when you're looking at most of the countries, it's between 1 to 10. And then further on, as you're coming on to, from that point onwards, where you can see the US and Australia and Russia and Pakistan, and these are numbers crossing 10 to 100. And then we reach the point where you have the whole of from Brazil, or maybe this is Indonesia, Nigeria, Brazil. You can see from there the numbers are crossing 100, and we are standing quite strongly between around 300 to 350. That was the last thing that was done. Now, these were studies that were done in the USA, and they were looking at the trends of type 2 diabetes amongst the various ethnic groups. And they did recognize a difference in the trends in the ethnic groups, but they also put forward a word of caution that this is, this is about time that we told ourselves, we awaken to this epidemic that is occurring amongst children and adolescents worldwide. Because if you look at the numbers from 2002 to where it was, marked that is at 2016, you can see the exponential rise in the numbers, as you went across the years and across the spectrum of the years. So if we try to understand that, if you're talking about type 2 diabetes in children and adolescents, what are the risk factors? Now, we know that this circle, the inner circle and then the outer layer, this is where we're talking about type 2 diabetes, and it is surrounded by this one circle of obesity. Now, not every person who is obese is going to develop type 2 diabetes. So then you have the other factors pitching in, which kind of increase the chances of a person who is obese into getting type 2 diabetes. And there you have the factors like the genetics, which is the next layer that is seen. But again, as you talk about it, not every person who is obese or has the genetics develops type 2 diabetes. So there is again where the other points come in. It's a very interesting picture. This is in a very, it's just one picture in one frame, but it is telling us so much about so many things that have an impact on the rising incidence of type 2 diabetes in children. Now, if we look at the various points, apart from the high calorie processed food and this sedentary lifestyle, there are also some distinctive features. For example, the intrauterine environment. So if the mother during the period of pregnancy was obese, or was in any of the spectrums of malnutrition, that is either having a very low BMI or having a very high BMI, or was diabetic, then it was seen that the chances, we do know that the chance of the child becoming obese or diabetic is much more. And there are so many factors that play a role here, starting from epigenetics to microbiomes. And there's so many, different pathophysiologies that we are beginning to understand, wherein a vicious cycle is created. Now, once one mother, she has a high BMI, she develops diabetes. It's not only about giving birth to a healthy child, but it's also about being carried on to the next generation and then to the next. So that's an interesting concept that we have understood today, and the impact of it, because we know that the rates of gestational diabetes is rising because of so many factors put together, and that is what is actually affecting the total risk that the children of the next generation are being put into. There are other interesting factors like, say, immigration, which has also been found out to be one of the reasons, that is one of the risk factors that is associated with the incidence of type 2 diabetes in the younger population. The concept of microbiome is coming up. Depression, anxiety, certain medications, and abuse these are also identified risk factors that have been seen to play a major role in the higher numbers of type 2 diabetes in adolescents and young adults. Now, when you looked at the prevalence of obesity in patients with type 2 diabetes, this is just one of the meta-analysis that has been done. So yes, indeed, obesity is a very strong factor when it comes to when identifying the risk factors, because this is one meta-analysis which is telling us that the prevalence of obesity was to the tune of 75%, and the prevalence at diagnosis was 77.24%. There was this study, which is known as the Today study, which looked into a lot of aspects of the diabetes in young adults, and they looked into various factors. And this particular study, this was done in the US, and they identified that this was not very prototypical. Here they found that more number of females were getting diabetes at a younger age. And then they looked at the family history, where there was a very strong impact of family history, 89.4%. And then they looked into the annual income, whether both parents, whether they were living with their parents, with the depression. All of these factors were taken into account, and this was a very comprehensive study that was done to identify the characteristics of adolescents and youth with the recent onset type 2 diabetes. With the data coming in from across the world, certain disparities have been identified in the type 2 risk factors. So when you're looking at the gender distribution, you can see that female to male in Canada was 6.1. In the Pima Indians was 5:1. Mexican American 3:1, and Japanese 1.2:1. But if you look at the figures from China, that was 1:1, and in UAE 0.5:1, Iraq, Kuwait 0.6, 0.8:1. So different figures there, and also the very interesting area, the socioeconomic status. We know today that while in the developed countries, the type 2 diabetes in adults, or young adults or adolescents, is more prevalent in the lower socioeconomic strata, which is attributed to lesser access to healthy food or healthy living. In contrast to that, in the developing countries like ours, type 2 diabetes is more often seen in the higher socioeconomic status, even in this adolescent and young adult population, then because of factors like sedentary lifestyle, and again, eating high calorie food and all, which is more prevalent in the high socioeconomic status. So some disparities there when you look at the figures across the world. And this is one study, the Prodigy, where they looked at the basic genome-wide association study for type 2 diabetes in youth, and they could identify certain known loci in their analysis. They found out certain loci which they said was associated with the incidence of diabetes, and they said that they identified the known and novel loci. And this was the first genome-wide study, association study for youth onset type 2 diabetes. There is also a concept that there's a seasonal variation in the which kind of points towards the onset of type 2 diabetes in a particular period of the year. And it was found that the diagnosis increased in August, and they were trying to put in explanation, and they said probably it's because of the summer vacation, increased weight gain, not increase in physical exams. But somehow across the world, a lot of data have said that most of the diagnoses occur in this period of the year. Now, when we're talking about adolescents and young adults, we still have it in our mind that these are, maybe 18 or 20, or, you would be talking about that. But when you look at data like these, where you're talking about pre-pubertal children, and this is a meta-analysis of these case reports that have come in from various places, from US, from Australia, Texas, and also from India. You can see that the mean age in some of them is like the range being 4 to 9, right? And this is the percentage of ages, and then you can see the female male distribution, the BMI. The BMI Z score, that's 2.7 and 2.5, 2.3, 2.4, and more than 97 percentile here. And they looked at the other features also, association of NFL. And remember, we're talking about a pre-pubertal population here. We're talking about factors like dyslipidemia, talking about NFLD, we're talking about hypertension, and we're talking about these children who are diagnosed with type 2 diabetes. So these figures, they make you think that, where are we going? What next? If you're talking about type 2 diabetes in prepubertal children, in adolescents, in young adults, and you're looking at the numbers, we'll just take a look at what our Indian figures show. Because we know that in terms of the youth population by countries, India is way ahead of the other countries. So we have a huge chunk of our population who are young, and with the increasing numbers of young people in our country, if you're talking of this kind of a non-communicable disease with its implications later on, numbers rising, then that leaves a lot of area for thought. We have to think about it. Now, when I was looking for the data with type 2 diabetes in children in India, this is a very interesting study that came up. This is 1991. So they were just looking at school children, and they were investigating for glycosuria and its causes. And they concluded that neither diabetes mellitus nor glycosuria is a crucial health problem in Indian children. So they just put it there. And this was, again, the childhood onset diabetes mellitus in Indian overview. And they said here, that childhood diabetes does not form part of undergraduate medical curriculum in many medical colleges because of the apparent rarity. This was 1990. When they looked at, this was another study done by the same group, and when they looked at the general hospitals, you can see 99% were type 1. 99, 88, 95. In private institutions, there was a slightly different picture, but still the figures were very much in towards type 1. Now, when you look at from there, 1990, and you look at 2022, this is the RSSDI countrywide Defeat Diabetes Community Program. This is, we're talking about, because the subgroup studied was like below 30 years. That's here, they said that below 30 years, 8.7% had pre-existing diabetes and 4.6% had newly detected diabetes. So that makes the overall prevalence of diabetes in the age group below 30 years at 13.3%. And when you looked at it in terms of the other studies which have looked into the etiology, so again, this study by Bhatia et al., type 1, 81, type 2, 8%, FCPD, 9%. This is again Unnikrishnan et al. This is 2008. They said 89% type 1, 6% type 2, and 3% FCPD. Then we had this YDR registry, because this is basically a registry which takes into account diabetes in young with an age with they look at the age of onset and then they look at the characteristics. This is from 2000 to 2011, and then when they looked at the data here, it was 63% type 1 and 25% type 2. So numbers quite ahead from what we were looking at in the previous studies. And then we had this study from North India by Sahu et al., where they actually said that type 1 and type 2 diabetes are equally frequent, 40% each, followed by FCPD. Now, this is something that was, that triggered a lot of controversy. They said, like, when you're talking about this age group, how can you possibly have this kind of numbers? We're talking about type 1 and type 2 being equal, but this they had the figures there, and there it was. So this is what needs to be thought about. We need to understand it. We are having changing demographics of diabetes in the young. And while we are into this discussion of the Young Diabetes Registry, the YDR I was telling you about, this is the ICMR registry. It's a national registry for youth onset diabetes in the world. And this has been maintained by the ICMR since 2006. This is for young onset diagnosed on or before 25 years of age, and there are various centers from 10 cities across India. And the registry data said that 65% were type 1 and the rest were type 2, so that's around 35%. And they did not mention this particular paper did not mention the other causes. Interestingly, what YDR has said is that there's a considerable overlap in clinical features. While we typically think that the type 1 child is going to be lean and the type 2 child is going to be overweight, here they said the type 1 diabetes in that subgroup, 21% were overweight, and metabolic syndrome was present in 10% of the type 1 diabetic patients. And with type 2, you generally tend to think that they're not going to have a very high blood sugar presentation, or they will have a high BMI. But look at this. 21% had a blood sugar level of more than 400. 29%, that's almost like 1/3, right? Now that's like 30%, almost 1/3. They had a normal BMI, and 64% lacked the classical acanthosis. Interestingly, also 7% of type 2 diabetic patients had detectable islet antibodies. Just putting in what they said about FCPD, that 31% had no history of abdominal pain, 62% lacked the exocrine insufficiency. And so maybe this category might be clubbed into the type 1 or the type 2 category, falsely diagnosed as either type 1 and type 2. So that also needs to be remembered. Are we different from the West, or are the studies, whatever they're telling us from the West, do they apply to us as well? So here we have a comparison with the search data, which looked into the data of the children in the United States, and our own data, the YDR data. See, when you're looking at type 2 diabetes, search, the age of diagnosis was 14. Here in our country, it was 16. And interestingly, when you're looking at the figures or the age, when you're breaking up the age, you can see that most of the patients who were diagnosed with diabetes between 10 to 19 years of age, can you see that? 15 to 19, that category actually, 51% had type 2 and 66% in YDR. So in that subcategory, most of the children who were diagnosed with diabetes 15 to 90 were type 2 diabetic patients as compared to the other age groups where mostly it was type 1, say younger age groups, say 0 to 9, mostly type 1, 10 to 14, the numbers were increasing in favor towards type 2. So 40% you can see surge, 21% in India. But 15 to 19, it goes up to 51% and 66% in US and India, respectively. Differences in India, type 2 diabetes made up 10% of all the youth diabetes cases, and in US it was 22%. Age of diagnosis was older for us as compared to the US population. Higher proportion of females in the US as compared to India. And for type 2 cases, the majority of in YDR were in the higher socioeconomic strata, which is something that we have looked into previously. And in the US, it was mostly in the lower socioeconomic strata. The US population had lower blood pressure compared to our population with both type 1 and type 2. And for type 1 and type 2, US population had a higher BMI and a lower A1C compared to our youth who had a lower BMI and a higher HbA1c. So young onset Indian type 2, because of the because of the increase in the number of youth in our country, and also the other factors put in, there's been an exponential rise in the number of type 2 diabetes prevalence in India in the last 30 years, which has hugely contributed to the burden of diabetes in this part of the world. And this was an editorial, a study where they looked at this. An editorial which looked into the study, and then they said that this is a big problem which is going to come up. This is in 2001 where they predicted this, that there are reasons to believe that this type 2 diabetes is just a phenomena waiting to declare itself in this young population. I'll just skip through this. This is interesting that this is a book on pediatric diabetes, and they said that gradually we're reporting more and more type 2 diabetes across the country. Referral centers like Lucknow and Chennai, it's like 12% and 26% of all children who come in with diabetes, but then numbers differ across the country. This is also an interesting area of consideration where they have looked into two cohorts of the Asian Indians, the ICMR India B cohort and the DMDSC cohort, that's Dr. Mohan's Diabetes Specialty Center, and one of the European cohort. Yeah, this is the ESDC, the East Scotland Diabetic Cohort. And they compared these three groups. So when you looked into the comparison, you can see, if you're looking at the BMI, the overweight category or the obese category, and you can see the percentage who are diagnosed. So you can see that in the obese category, it's the Europeans more who are diagnosed, but in the overweight category, it's almost the Indian data is kind of hovering around the same place. But when you're looking at the normal BMI category, you can see that the ICMR India data, the numbers are way higher, which means to say that our population is presenting with type 2 diabetes in this young cohort at a much lower BMI, at a normal BMI as compared to the European population. And also, when you looked for the cumulative distribution of the risk alleles, the percentage of the Europeans with 8 or more risk alleles was 25%, whereas in our population, the South Asians or Asian Indians, the numbers were 45%. So, if you're looking at these, if you can identify these risk alleles, and you're talking about 45% of them having these risk alleles, this could actually add a lot to our understanding of stratifying our patients in their risk for type 2 diabetes. Also, importantly, while we are being diagnosed with a normal BMI, the beta cell function has been seen to be much lower. You can see the C-peptide levels while comparing across the studies with the European population, much lower when they're diagnosed with type 2 diabetes, even in the younger population who are overweight or obese. So these are studies, again, which have told us that the subgroups of patients with young onset type 2 diabetes in India have revealed insulin deficiency as a major driver, even in this younger population. Also, the rate of progression from pre-diabetes to type 2 diabetes is higher in the Indian young diabetics, that is 14 to 18%, as compared to US, the population, which is just 2.5%, in Finland, which is 6%. So these are areas of study, because we have to study our population as distinct from the Western population and understand them in their own perspective. This is looking at the predictors of the cardiovascular risk factors, the longitudinal data. And what they said was that if you're comparing it with the global data, what was seen is that the prevalence of diabetes and hypertension is higher than that expected relative to the urban. So at the same BMI, you're not saying the same thing. Basically, you are getting type 2 diabetes in young at a lower BMI as compared to the West. Genetic studies, again, these are studies which have been done in our country, looking at the analysis of the various susceptibility genetic various trends. And some of the studies that were done in the West were replicated in India. This is, again, a strong association seen with the FTO gene. This is in the South Asian Indians, and particularly the North Indian Sikhs. And these could have important implications. Understanding the complications and comorbidities for this population with type 2 diabetes, we're relying a lot on the US data, because most of the studies that have kind of accumulated evidence came from the Today study or the Search study. And what they told us is in the Today study is that the cumulative incidence of any microvascular complication was 50% by 9 years and 80% by 15 years. So if you're talking about a child who's been diagnosed at 12 years of age, by the time the child is like 27 years, goes up to 27 years, the chance of a microvascular complication, cumulative incidence is 80%. So diabetic retinopathy was present in 50% of the participants by 25 years of age, 35% cumulative incidence of peripheral neuropathy 15 years after diagnosis, and a cumulative incidence of 55% of diabetic kidney disease after 15 years of follow-up. In the Search study, slightly different figures, but again, type 2 diabetes had a higher prevalence of retinopathies compared to type 1 diabetes, high prevalence of DKD, high prevalence of peripheral neuropathy. And they said that DKD was present in 20% of the population in the studied 8 years after diagnosis. Also, peripheral autonomic neuropathy, 21% and 57% after just a median of 1.3 years. If you're looking at macrovascular complication, Search study said that the higher age-adjusted prevalence of arterial stiffness, hypertension, also ischemic heart disease and or CVA was observed in 14% of type 2 diabetes patients compared to 6% with patients with type 1 diabetes. The Australian study also said that hypertension was more common in patients with type 2 as compared to type 1 patients in the age group of less than 15 years. Mortality, Search participants who were diagnosed between 2002 and 2015, it was seen that mortality amongst youth and young adults with type 2 was 1.5 times higher than those with type 1. In our own country, we have these data with type 2 DM in young population. This was also telling us about similar figures in terms of complications. This is another study by Bhatia. They said the frequency of microvascular complication is comparable with that of the Western literature. I'm not going through the details because we're falling short of time, but we'll come over to the treatment options. Now, once you have diagnosed type 2 diabetes in the child, in the adolescent, in the young adult, what are the options? First, of course, you'll talk about lifestyle changes. So this is the Today cohort where they actually took all these young children, 10 to 17 years, and they put them through a vigorous lifestyle intervention with a family-based behavioral program, a targeted lifestyle change intervention program aimed at promoting weight loss. Now, what did they see? That at 6 months, 25% of females and 33% of males had better cardiovascular fitness. And they concluded that a minority of youth improved fitness and or diet over time. Importantly, while the importance of lifestyle changes remains very strongly, but what this study said was that the positive changes did not persist after 24 months, providing a sobering perspective on the challenges of implementing a lasting lifestyle change in this population, in this young population, where it's difficult for them to hold on and carry on with those things that you could start, or the parents or the family members can force them to do certain things, but to carry it forward, you can see after 2 years, most of them did not carry on the lifestyle behavioral changes. So you then have to fall back on medications. These are the medications that have been approved in children 10 years and older: metformin, the GLP-1 receptor agonist, liraglutide, exenatide, and dulaglutide have been accepted as SGLT2 inhibitors, empagliflozin and dapagliflozin have been given a clearance for use in children above 10 years of figures with the use of these molecules in comparison to the control group with placebo. And you can see lira, exenatide, dulaglutide, empagliflozin, dapagliflozin, and lina and seta being put there. But yeah, so that is what is available as of now for the treatment of type 2 diabetic children. So lastly, winding off with the takeaway message. Takeaway message: prevalence of type 2 diabetes is increasing exponentially across the globe, but particularly in some countries like ours, there's a very, very steep upward trend. Contrary to common perception, not all adolescents with type 2 diabetes are obese. Only 70 or severely obese, only 70 to 80 fall in this category. Socioeconomic status plays a significant role. Adolescents are, because we know because of the puberty and the hormonal changes that come in, that adolescents are at a higher risk of developing type 2 diabetes, and also because of so many other factors. But we are today also having reports of children developing type 2 diabetes younger than 10 years of age, and that needs to be remembered. Gender distribution varies across the world, as we discussed. Promisingly, there are these newer group of medications which have been approved for the use of in this for diabetes in this age group, which also help towards weight loss. We also very, very importantly need to understand that if you're starting with diabetes so young, what is going to happen across the years, the risk of complications, the microvascular complication, the increased risk of mortality, and the morbidity that is associated with starting off with a disease, a chronic disease so young in life, and the implications in terms of what the child actually goes through when it comes to meal planning or activity planning, or having to take the medicines, and all of it put together, and looking at the testings, the visit to the doctors, all of it put together. When we look at where things stand today, it is indeed a very grim picture, and where we stand as a nation with so many young people in our country at a risk of developing this disease, we really, really need to think about it hard. Each of us as doctors, as caregivers, as family members, we really need to think about it and play some proactive role in stopping this progress of this epidemic of type 2 diabetes in the adolescents and young adults. So on that note, thank you so much. I'll hand back to Dr. Archana.
Yes, thank you, Arundhati. Thank you so much. Great. So we had two wonderful talks, one on all types of diabetes other than type 2, but still a comparison. And now we had a lot of the epidemiology as well as treatment options for young people with type 2 diabetes. So we have a lot of questions. I will be going through them. Let me introduce Dr. Nitin Kapoor, who has joined us. Dr. Sanjay Agarwal is here, and this is the IDEC team for you. And Dr. Nitin, would you like to start while I go through the questions that have come in?
Sure, and I believe absolutely very, very good presentations we had today. Maybe if I can start asking with Dr. Arundhati, and there are a lot of questions. Thank you again for that great talk, very comprehensive. I would ask a question, a very common question from the clinic, a scenario wherein a patient walks into our OPD, maybe early 20s. He's got blood glucose values of 200, not very obese, but not very thin either. Maybe not significant family history of diabetes in the young. Not ketotic at that point, but if you could just give some clinical pointers as to what would really make you think this is type 2 diabetes, be it clinical, be it investigation-wise, maybe a quick checklist for all our clinicians who've joined us today. A young patient who's walked into the clinic, neither fitting in classic type 1 or type 2, what do we do?
So as Dr. Ganesh had very, very strongly said, that you need to definitely rule out type 1. Not all of them will come in with the classical features of polyuria and polydipsia and ketosis. Yeah, so we're going to check definitely 20 years. not obese, no family history, as you're putting it, I will have to rule out type 1. We will take a look at the antibodies. We'll take a look at the C-peptide level. We'll try to take a look at the other clinical markers of insulin resistance, and also the other, the lipids or the blood pressure and the other marker of the aspects of the metabolic syndrome if they exist. So once you have not ruled out, I would say, as Dr. Ganesh has told us, that not all of them are going to have positive antibodies, or ketosis can also be very difficult in its presentation at times. So once you have kind of seen that the patient has no ketosis, C-peptide levels are good, there are no antibodies, as such, the patient is not in a catabolic state. And that is where you would start thinking of type 2 diabetes, and you've kind of ruled out the pancreatic factors unless they have very strong. Because, when I was going through this YDR thing, it is surprising that there were so many FCPD patients who were basically diagnosed as type 2. And then they went on to be diagnosed to be FCPD later on. So maybe a quick look at the ultrasound, the pancreas. This would help you place the patient in one of the groups. You might have to change later on, as we saw from the case that Dr. Ganesh had presented. Sometimes it happens that you kind of do not put in the right thing, but usually I think you are able to generally place them, because if they're walking in 200, 250, no ketosis, no catabolic presentation, you would generally not think of type 1, but you would have to rule it out with the tests that have to be performed.
Thank you for that answer. And yes, I think especially in the South, we do see a lot of pancreatic diabetes. It was first reported in Kerala, but still today, I would say in my practice, a significant proportion of people actually have pancreatic diabetes. They don't have those classical symptoms of, steatorrhea, abdominal pain. Not all of them have it. And so this has to be definitely ruled out. Maybe just one other question, Dr. Arundhati, before we move on to Dr. Ganesh. You mentioned about obesity as a big problem in young children, and that is one of the key drivers for type 2 diabetes. Completely agree. But with so many newer drugs coming for obesity management in adults, what do you think would be their role in children? Because, in adults, we are seeing these drugs need to be taken long term. So what would you think in future? Are we going to be able to apply those same drugs like tirzepatide and retatrutide to children? Or semaglutide, the injectable semaglutide?
Well, while the data that we have today with adults is very encouraging in terms of, I do not really know how much that will translate into a practical solution for children. We'll have to wait and watch. We also have to take into account that, there is a huge resource area that is involved out here. Resource in terms of availability of the medication, in terms of the financial aspect of it. So to what percentage of the population will we actually be able to give these groups of molecules and help them in terms of obesity reduction is something that has to be seen. It's promising, but then we'll still have to keep the other areas working, because not everybody will have access to these molecules, I guess, and so we'll have to think of the others.
Completely
Dr.
agree.
Ganesh, would you, sorry, just Dr. Ganesh, would you like to comment on that? Are you using any of the molecules that have been suggested? How often are you using them for children with type 2 diabetes or obesity in your clinic?
So as of now, I'm not using anything other than liraglutide. Liraglutide has been approved for use. But we do see a good weight loss with liraglutide. But the most common problem that happens is that after first few months, people stop taking liraglutide for some reasons. They just make reasons that, the daily injection becomes a hassle or whatever. But at least in the patients that I have used, invariably everybody has stopped after having a good weight loss. And then obviously the weight story often rebounds, because that happens with most of the weight loss therapies, that there is a weight rebound. With respect to the newer molecules, it does seem attractive. So it will be exciting to see what kind of studies come and what kind of experience, because anything to get translated to pediatric age group or adolescent age group, it takes a little while. We also have to consider the growing skeleton and growing the growth part of it, because these weight loss therapies could be associated with issues such as bone mineral accrual or etc. So I think there are lots of things to be looked for, but it is obviously very interesting what kind of studies will come up. Definitely, there will be studies done on these molecules.
Sanjay sir.
Yeah, just a couple of, and to this address to all three of you. What is the kind of a body composition analysis that you get in obese, adolescent type 2s? That's one, and perhaps Nitin may have some work there. Two is, how long do you continue your liraglutides or GLP-1s in children? Do you persist, and what is the kind of weight regain that you see if you do stop, after, since you use liraglutide a lot, how long do you use it, and do you find the challenge of a weight regain? And three, do you see a lot of muscle loss also, when they lose a lot of fat mass loss in children? So what is your sort of perception? Is it different from adult in the way they respond, or is it very similar to the way the adults respond? So any of you can address this.
So, like, if I start, then with respect to pediatric obesity and type 2 diabetes, it is very frustrating as compared to type 1 diabetes also. I mean, not that the type 1 diabetes follow-up rates are great, but pediatric type 2 diabetes follow-up rates are miserably low. They are really, really low. I mean, most of these patients just stop adhering to treatment or adhering to any lifestyle things. Invariably, most of them have ongoing weight gains. With respect to your question about liraglutide, in whatever patients, it's just a handful of patients that have used liraglutide for. We do get good weight loss, such as like a couple of my patients lost from 120 kgs to 99 or 98 kgs. So that kind of a thing over a period of 6 months to 9 months, I would say. But most of them have stopped taking liraglutide for some reasons and have therefore like subsequently have had a rebound of weight gain. I have very limited experience with the weekly GLP-1 analogs, maybe just a couple of patients. I'm not that data is not enough for me to say whether compliance with weekly is better or not. The oral GLP-1 analog I've maybe used for a couple of patients close to 18 years of age. Again, the cost seems to be a prohibitively, one important factor there. And with the lower doses, probably the weight loss is not that great as compared to, I see a better weight loss with daily injectable GLP-1 analogs.
Dr. Nitin, do you have data on the young people body composition, as I was saying? Would you like to
so there are two studies that we have done. One is in the population of PCOS. I would say all type 2 diabetics, but yes, many of them with pre-diabetes and some of them with diabetes. And I think the important point that was highlighted before was that we do see a lot of these patients with high body fat percentage, which is disproportionate to their BMI, even in the younger population. We keep talking about this thin fat concept in older people, but these young girls with PCOS who are thin, this so-called lean MAFLD or fatty liver disease, I think this is where the importance of body composition really, really highlights much more, because those who are overtly overweight or obese, it is but obvious that they have high fat. But these young girls with PCOS and those who come with a diagnosis of fatty liver, so they have definitely high visceral fat, high total body fat percentage. Our biggest limitation at this point is we do not really have good cutoffs to define how these body fat percentages change over time, because it depends not only on the age, but also on the pubertal status of the person. And during teens, especially, moving from pubertal stage 3, 4, this changes significantly. So interpretation is okay if you have, within the same patient after puberty, but during puberty, interpretation of this is difficult.
Right. On that note, I would just read out a question. They're talking about weight loss surgery in teenagers. Is that an option? So any one of you, please. Dr. Arundhati, Dr. Ganesh.
So bariatric surgery in the young population, it has been done. It's not like it has not been done, because particularly in those who've been, or morbidly obese or very obese, not a lot of data. I do not know of a lot of data from our own country. Whatever I read was mostly from the Western. Results were good as expected but there were also concerns. There was one particular study that I read, but the initial results were very good, but the follow-up was not that good, because these children did not stick to many of these children, as compared to the adult data. The later on weight gain was a little more. This was one particular study that I had read. I do not know about the pediatric surgery being done in young population in our country. If my fellow panelists could maybe throw some light, I don't know.
Right. So now I move to some very basic questions, and this is about investigations, and this is something that our audience wants to know. First is where do we place the oral glucose tolerance test? I know this is very basic, but whether Dr. Ganesh, Dr. Arundhati, both of you, I would like you to answer that. Second is going to be about HbA1c as a diagnosis, whether it's for type 1 or for type 2, especially for type 1. And third is C-peptide. Specifically has been asked for LADA, but I would like you, both of you, to take us through the right time, right way, right diagnosis with C-peptide. So maybe we will ask Dr. Ganesh right now to address it, especially in type 1.
So with respect to OGTT, I emphasize the fact that most people with type 1 diabetes do not need an oral glucose tolerance test. Their diagnosis is self-evident. Actually, we waste time and probably increase the risk of ketoacidosis by doing OGTT in these individuals by subjecting them to a very high glucose load. So it's not required in type 1 diabetes cases. So OGTT is important for screening for pre-diabetes or diabetes in obese children and adolescents. It is also important in probably in type 2 diabetes cases where the results are a bit equivocal. In type 2 also, if you have symptoms plus very high blood sugar, which happens with many young type 2 cases, there also you don't need OGTT. So only if you have equivocal kind of fasting glucose values or HbA1c values, there you would need oral glucose tolerance test. With respect to HbA1c, most of the times in type 1 or type 2 diabetes in children, HbA1c is also clearly elevated. I would probably interpret borderline high HbA1c values with a bit of caution. Particularly, a lot of values come in the pre-diabetic range with blood sugars being absolutely fine. And there, I don't think we need to unnecessarily raise alarm button. What would be more important if we follow these HbA1c values maybe at a periodic interval, and if it is showing a rising trend in a sustained manner, that is something which would have more value than isolated single value of a borderline, especially in the pre-diabetic range kind of HbA1c. The third question was about C-peptide. C-peptide, we do find C-peptide to be, I would say, a bit useful in overweight or obese individuals with presenting with diabetes with various degrees of hyperglycemia. As I said, that C-peptide has more value beyond first 1 or 2 years of diabetes onset. Obviously, at diagnosis, if you have a high C-peptide, that would be kind of going more towards favor of type 2 diabetes. But normal C-peptide can be seen in both types of diabetes. In type 1 diabetes, you could have a good amount of insulin production, especially after the initial hyperglycemia control in the first couple of years. So you could have C-peptide values falling in the normal range. And in type 2 diabetes, because of glucotoxicity, you could have C-peptide in the low range or low normal kind of range also. So that is important. Also, in young type 2 diabetes, there is a significant component of insulin secretory defect, not just insulin resistance. So that is also has been highlighted in several studies that pediatric type 2 diabetes is a more aggressive disease, and they may go on to require insulin treatment much earlier in their course as compared to adults with type 2 diabetes. So C-peptide will be useful parameter. Again, nothing is useful in isolation. We have to put the whole picture jigsaw puzzle together. It has to be the clinical picture plus your clinical signs, blood sugar values, ketones, family history, and your antibody C-peptide, etc. It's not only that one, these are not individual things.
Right. Thank you so much. On the same note, Dr. Banik has asked about diagnosing LADA. and the role of C-peptide there, as well as the treatment. Is sulfonylurea the first line? So, Dr. Arundhati, would you like to answer that?
So LADA is basically a condition where the patient was initially maybe diagnosed as type 2, did respond to OHAs. The classical picture that you're going to see is there's a failing response to the OHAs. And there is where I think there is the role of C-peptide is coming in. That is an area where you would use C-peptides. You could also use antibodies. But generally, when you're talking about when we're talking about treatment of in the peripheral level, we are not only talking about treatment at the tertiary level, right? So we're talking about treatment at the secondary, the tertiary, at the peripheral levels also. They do not have access to C-peptide. They do not have one test of C-peptide. You'll get the report after so many days. Autoantibodies. I mean, this. I was also going to talk about the HbA1c levels, and so LADA is a condition where you are looking at the falling C-peptide levels. You're looking at the failing response to the OHs, and that is how you are basically diagnosing LADA and then going ahead. I would not say sulfonylureas because that is basically against the concept of the autoimmune destruction. You would generally want to choose insulin in these patients. I personally use insulin in these patients a little earlier on. That maybe helps me to sustain that little bit of insulin, whatever is left. So I personally am a believer of that. If you're diagnosing LADA and there's still some amount of insulin activity left, let it be there. Use a little more insulin, keep it in there. So LADA is that. I would just want to add on something to what Dr. Ganesh had said. I have seen a patient, a young child who had all these symptoms, and he had an HbA1c done. And the RBS was done in a glucometer because I practice at a tier 2 city and I see a lot of patients coming from rural areas, and they looked at the HbA1c and HbA1c was something very normal, and the patient was not diagnosed to be a diabetic, whereas actually the patient was a diabetic, and that random and that HbA1c said everything already. So while yes, HbA1c is very important for those of us who are practicing in areas where not all our patients have access. In my center, I have it, but they don't have it in their villages. So HbA1c, yes, it's important, but you have to also see where is it being done, which laboratory. I cater to a huge population who have hemoglobinopathies, and it gives me a lot of problem when I'm treating these patients. So HbA1c, as in the adult population, younger population also, you'll have to be a little careful in assessing the data. So,
thank you. So I see a question here about, does type 1 diabetes affect joints? And that is for Dr. Ganesh. And how does it affect?
Well, there could be different ways in which the joints could get affected. Like the most common is if you have children who have very poorly controlled diabetes, they tend to develop kind of contractures of their limbs, upper limbs. And if you ask them to do a prayer sign, they will not be able to kind of join the hands like this. They would be this. This is called as diabetic chiroarthropathy or limited joint mobility in type 1 diabetes. This is a sign of especially like very bad control, and it correlates with the incidence of microvascular complications in type 1 diabetes. Obviously, type 1 diabetes is an autoimmune disease, so some individuals could develop autoimmune arthritis, different types of autoimmune arthritis. Although, like at least in my experience, maybe like none of my patients have had arthritis as an autoimmune coexisting condition, but theoretically it could be an accompanying condition.
So I think we have come almost to an end of all the questions that are in the chat box. Dr. Nitin, anything you would like to ask before we ask the panelists to conclude with their take-home messages?
It's been wonderful listening to both of them. So it's just the time has just flown by. I didn't realize. And thank you for both your lectures, and back to you, Dr. Archana, for the take-home messages that they're going to give us.
So, Dr. Arundhati, what would be your take-home message regarding type 2 diabetes in the young for our listeners?
So it's not a take-home message. It's It's an understanding, I would say, that every time we talk about type 2 diabetes in the younger population and we're talking about rising numbers, we actually need to understand it in its total perspective. What is that going to translate into 20 years, 25 years from now? If, this huge burden that is already there in the adult population is coming down, the threshold coming down, and the numbers increasing, the complications increasing, what is that going to translate into? And what are we doing actually as doctors, as metabolic physicians to stop that even a bit? Are we doing everything in our capacity? I think that is the question that is always there in my mind. And that is the question that I would also like to put. Are we doing our bit, or can we do a little more? Because we can see it. The others can't see it. I mean, those who do not know about this, they can't see what's happening. We can see it. So are we doing enough? That is the question I think we need to ask ourselves and everybody. That's it.
Thank you. Thank you so much. Before I move to Dr. Ganesh, there's just a couple of questions that have just come in and I don't want to leave them. Dr. Meena has asked whether a young person with type 2 diabetes is planning pregnancy. Do we continue metformin along with insulin? Dr. Arundhati, would you like to answer that? So a young lady with type 2 diabetes now wanting to get pregnant, do we continue metformin?
We can continue metformin. Yes, we have enough data to telling us that it's all right to continue metformin. Apart from preterm delivery, the other concerns are not majorly theirs. And also there are some positive aspects to the using of metformin. So yes, if you see your patient as being well controlled with some amount of insulin and metformin, I personally, continue it. However, I always put in that line, adding that guidelines still do not recommend the use of metformin if you're okay with it, because you never know what's going to turn up another 10 years from now. So I put in that line, but I generally continue my patients on metformin if they're planning pregnancy. Yes.
Thank you. Over to you, Dr. Ganesh. What would you like our listeners to know, especially when it comes to type of diabetes in young and the confusion around its diagnosis?
Yeah, I mean, before even confusion, I would say that keep in mind that common things occur commonly, and type 1 diabetes is the most common type of diabetes in children and adolescents. And a message has to uniformly go across the healthcare fraternity from us to the patients that people with type 1 diabetes have to be managed with physiological insulin regimen and not some shortcut once or twice daily or that kind of insulin thing. They have to be on basal bolus treatment or insulin pump, whichever the situation permits, along with adequate blood glucose monitoring. With respect to other types of diabetes, I think that we as a clinician, when we individually see each and every case we have to question what type of diabetes it is, irrespective of however straightforward it may seem. Unless and until we suspect, we will not diagnose. So I think every case has to be seen individually, separately.
Perfect. That sounds great. Thank you so much. From my side, I would also like to say that we are talking about a very young population. And this is the population who needs a lot of hand-holding when it comes to their feelings and the way they perceive. So another aspect I would appeal to all clinicians is the language we use, the way we address these growing young people, whether it is obesity leading to body shaming or leading to anxiety, because we often end up using fear psychosis in the patients, parents saying that tomorrow they will have all these complications, while everything is true, yet to motivate them, to want them to adhere to the therapy, to not let them sleep or not sleep or leave everything or rebel because of the anxiety it can create. So I think the language we use, the way we approach, maybe we all learn to be a little more empathetic. Behavioral therapy would be a part of our team care. And I know it's tough to have people on our team, but it is something we could learn over time and would be a key factor, along with, of course, everything that goes in the science of diagnosing right and treating right. So with that, I would like to conclude that we had a wonderful session here. Thank you, Dr. Ganesh and Dr. Arundhati. We really covered a topic which has so many controversies, still less known, and still, I think more and more physicians are seeing very young people, and pediatricians are now following up with their type 2 diabetes in their clinics. And this was something that all our audience wanted to hear. And I'm sure they're very happy today. You can also follow this on the IDEC website. This talk today would be available on the IDEC website in, say, another 2 weeks. And that is when it can be shared with everyone else for whoever missed it today. So stay tuned for every fourth Wednesday night for Wednesday Cafe for many more such topics. And thank you to our panelists for joining us tonight and all the audience from across the world who was here till this late hour. Thank you so much.
Thank you so much.
Thank you and good night.